psychiatry professor. He came, he also given this guy. For 7 days we used to talk to him morning, evening, morning, evening, morning, evening, and my residents, whole of my team was with him. And I told him that this boy should go completely pain-free, whatever you do. So what we have done, just one antidepressant professor secretary has given him, and one Lyrica, that is pregabalin we have given him, that is 75 milligram at night. And you know, he has stopped using his telephone. He stopped talking to his friends. Since last 6 months he has not, he stopped talking, and he was not talking to anybody in front of us. When we used to show me your first performance which you did. So he used to show his we used to take him on the internet site, and he used to show his first performance, second performance, third performance, and slowly he has recovered and he started doing. And now last week I talked to his father, and he said that he's completely well, madam. He's now ready to go to Bombay again to perform. So this is the way. See, the neuropathic pain. This boy is having severe neuropathic pain. So this boy, if we'll go to any of the pain center, they will treat him for the neuropathic pain. And neuropathic pain, yesterday we listened that it is such a complex entity. We just cannot treat. We always remain almost failure of treating neuropathic pain. But what was the component? So pain, even whether pain is malignant or non-malignant, patient is patient. We have to treat patient as a whole. When we start treating patient as a whole, all youngsters I can see, when you start treating your patient as a whole, you will become the best pain physician. As a whole, how will you treat? Just see, the psychiatry professor has come only once, but rest of the work my team has done. They used to talk to the boy regularly, morning, evening, and whatever fun they can do is like whatever he wanted to do. He wants to watch a movie, everything we did for him, and within 7 days, this boy was completely pain-free. Back to the quality, back to the life. He was very lively boy, and he is ready to perform for our 7th November pain conference, neuropathic pain conference, that I am ready to do this. So this is the way we can treat patient, whether it is malignant or non-malignant. So you start treating patient as a whole. If you will start treating whether it is malignant or non-malignant, you will become a good pain physician. One more example I will give. We have conducted an ICMR sponsored trial, and what we have seen, that even cancer pain, component of physical pain is only 35.5%. We have analyzed 300 patients, initial 300 patients. It is a total 600 patients trial, but initial 300 patients says only the physical component of pain in malignancy also. When we think that in malignant pain is only physical pain, it is severe and excruciating, we start giving medication, we start needling. So even in cancer pain, the psychological component is only 35.5%. Rest is, physical pain is only 35.5%. Rest all is psychological, social pain. How will my children will do? Who will earn for my children? What will happen to my girl who is eligible for marriage? All these pain are the most important pain, and once you remove, you cannot provide money to the patient. You cannot do anything. Only thing what you can do is the honest communication, honest conversation, realistic hope, what treatment we are going to give, and this is the way we can treat our patient. Okay, so this is another example which now which is very, very relevant in this context. Now we will come back to WHO ladder. Now the treatment part. So WHO in 1986 has given a ladder and protocol based treatment for this. I think we can skip all these things and then we come back to this WHO letter. So this letter was given in 1986, and this was a letter which was given for malignant pain, cancer patients' pain. So definitely, if a non-malignant patient is coming to you, based on this letter, we can treat 80% of our cancer patients very well based on the letter. I will not go into the detail of the letter, but 80% of pain can be relieved. In the we exclude the two components which we do in our practice definitely, that if a patient who can be very well treated with early intervention. For example, a gallbladder patient who is having very localized pain, and we think that with the celiac plexus block this patient will get very good pain relief, then there is no need to start oral morphine. Rather, we should give immediate relief and give celiac plexus block, and the patient will be relieved, and we can prevent the consequences, side effect of oral morphine. So early intervention is one part, and the rest of the 20% of patients, those who cannot be relieved with this ladder, then we can do interventional pain management. So this is the protocol for cancer pain. For non-cancer pain, I will not go into the detail, but non-cancer pain, again, I am telling you, please start talking to your patient. Start listening to your patient. And all variety, whether it is osteoarthritic pain, whether it is pain because of the lumbar canal stenosis, whether because of the disc prolapse, whether because of the multiple sclerosis, there is a certain protocol available. We should make our own protocol, but these protocols are available, regimes are available. But if you will follow only the regime, drug regime, then you will not be a successful pain physician. Start talking to a patient, start discussing, and give him a very important this thing, that give him a acceptance and affirmation that whatever will happen to you, I am there with you. This is what your patient needs from you. Don't depend most of the things, most of the time, on intervention. That's what we were discussing, that pain physician is not only for needling. Pain physician should be for whole of a patient. No, only nerve block is not pain management. Again and again I am telling you, only nerve block is not pain management. Start talking to your patient. Most of the problem, 50% of your problem will get solved. You must have seen in your pain clinics, when patient comes to you, he is in severe pain, they cannot sit down on the stool and they are severe screaming. Slowly you start talking, and after some time you see that the same patient is sitting nicely, telling his trip very nicely, because you have talked to for 2-3 minutes, and they start saying, and the pain get reduced. So intensity of pain can be reduced by good communication. So communication is the key of success. Whatever you do in both the pain, our aim should remain these three, that we have to give maximum pain control. Whatever drugs we are giving, we should minimize the side effects of the drug. Functional ability should be the maximum, and most of the time, most important thing, that whether it is malignant or non-malignant, quality of life should be the best. Attention to the details is very important. Treating patient with the balancing the side effects is very important. This is another example. I think I am now short of time, which we have conducted this study, but we will not go into the details. Early intervention has a role, which we have published also. Communication is the key of success. Many RCTs, they have done wonderful. The Google is full of articles giving emphasis on good communication for a pain physician. Communication, there is a level 1 evidence that communication makes a lot of difference if you want to treat your patient. If you are a busy physician, stop. If you don't want to give your time to your patient, stop practicing pain. Time is very important. It is not that we need half an hour. Even 5 minutes, if you are giving honesty to your patient, that is more than enough. Okay? Before leaving his patient, yeah, time is over. Yeah, I know. Thank you. And humanity. This is my favorite slide, which I show to everybody, that humanity is a wonder drug. Remain human, and then only you will be able to treat your patient very well. Thank you very much.
Thank you very much. Because we are running short of time, so only two questions can be asked from the audience.
No need of question. We will discuss
After that.
Yeah, our next speaker is Dr. Sameer Gupta, who is a consultant in anesthesia and pain management at Sheffield Teaching Hospitals, Sheffield. And And he's the chair and organizer for South Yorkshire Pain Group and co-director and instructor for care of critically ill surgical patients. And he's also teaching in pain for undergraduate students in Sheffield. Dr. Samir Gupta.
Thank you for that kind introduction for myself. Thank you. Thank you for inviting me here. I work in Sheffield. I will be presenting something slightly different to what Dr. Bhatnagar has just presented about the needle techniques. This is more about needling, but with rationale, with humanity, as what she said in that. But let's go. The first attempts, as she has said, was in mid-80s by the WHO as an analgesic ladder, and it helped a lot of people, no doubt about that. But the problem is whether the WHO ladder is still relevant in the cancer pain patients. The answer to that is yes, it is relevant, but it needs further updating because it has got limitations. Despite WHO ladder, we see lots and lots of people who suffer from pain. And in some people, we can definitely make a lot of difference. And one of the limitations of WHO ladder is that there is no role of interventions. And the other aspect, what Dr. Bhatnagar has just alluded to, what Dr. Bhatnagar has just alluded to is coming in big way. We are treating cancer pain as more like a chronic pain, including biopsychosocial model on that basis. So I fully agree with your thoughts. Other point that she alluded to is the biological cause. That is what exactly is causing the pain. That is the most important aspect before you consider any sort of intervention. When I talk about intervention, it could be anything. It could be medications, it could be injection therapy, or it could be psychotherapy or whatever. But probable cause needs to be understood. And this aspect, as we alluded to, is very, very important. But despite this, there is a clear recognition that cancer pain people need better pain management. Medications have their limitations. Invasive treatments are underutilized, and there is a call for better understanding between specialities. The way we work in the United Kingdom is that we have a palliative care people who look after the end-of-life care pathway, and then we've got oncologists, and then we've got pain physicians. So these three specialities work together. In terms of medications, these 4 medications have made a lot of difference over the last 15 years. Methadone, ketamine. Ketamine infusion was just alluded to. In our pain practice, we do burst ketamine infusions. We don't do it. Palliative care physician does it. The way we do it, we only do the needling techniques. We don't involve ourselves compared to these medications. We would leave all these medications for the palliative care physicians to look after. So if a patient is not benefited by these medications, or they are having lots of side effects, let's say for example, they are having a lot of sedation, then only we will come into the picture. So the domains that I'm going to talk about is the general principle